Welcome back. Let's wrap up the suicidal and homicidal ideation lectures with some situations you may encounter in the field. Let's bring this together with a real world scenario. You are dispatched for a psychiatric problem, possible overdose. On arrival, a roommate tells you her 22-year-old roommate, Sarah, has been very depressed lately. Tonight, Sarah posted a message on social media saying, "Goodbye, I love you all, I'm sorry." The roommate got worried and called 911. You enter the bedroom and see Sarah sitting on the bed, hunched over and crying uncontrollably. On the floor, you notice an empty pill bottle that the roommate says was Sarah's antidepressants. Amitriptyline 30 pills were newly filled. Your partner discreetly picks up the bottle. Sarah looks at you and through tears says, "I just want it to stop. I just want to die." How do we handle this? First, scene safety. No weapons visible, and it's just her and the concerned roommate. You kneel down a few feet from Sarah at eye level and softly say, "Hi, Sarah. I'm Megan, a paramedic. I'm here to help you." She doesn't look up, just cries, "I can't do this anymore." You maintain a calm, gentle tone. "I'm so sorry you're feeling like this. Can you tell me what you took? Did you take these pills?" She nods. "I took them all." Now you know this is a suicide attempt via overdose. Immediately, you signal your partner to get the oxygen and prepare to treat a possible overdose. Sarah is still conscious and breathing fine for now, but 30 antidepressants could cause serious issues. While your partner checks her vitals, you keep talking. "Sarah, I know you're hurting. I'm glad your friend called us. We're going to help keep you safe." She keeps sobbing, saying things like no one can help her. You ask directly, "Sarah, are you still thinking about wanting to die right now?" She replies through tears, I I don't know. I just don't want to feel this pain." You follow up gently. "Have you thought about anything else to hurt yourself tonight besides the pills? Any other plan?" She shakes her head no. "Good. Only the pills, which we are now treating." Medically, you check her blood pressure, etc., and call medical control who advises transport and monitoring for any changes. You place Sarah on oxygen and monitor her. ALS providers should monitor for metabolic acidosis and treat with sodium bicarbonate if necessary. Now, compassion. While doing all this, you sit next to her, maintaining a friendly posture, and say, "Sarah, I know you feel awful right now, but I need you to know you're not alone. We're here with you. We're going to stay with you and get you help." She whispers, "I'm sorry." You respond, "You don't need to apologize. I just want to make sure you're okay. Your friend was really worried about you. She cares about you a lot, and so do we." She nods, maybe feeling a bit understood. You ask if it's okay to place her on the stretcher to go to the hospital. She's hesitant. "I don't want to go. I'm fine." This is where you kindly set expectations. "Sarah, because you took those pills and you said you want to die, we really need to get you checked out at the hospital. The doctors there will take care of you, both your body and someone you can talk to about how you feel. We want to make sure you're safe. I'd like you to come with us. I promise to stay with you the whole way." She eventually nods and doesn't resist as you and your partner help her onto the stretcher. You allow the roommate to ride along in the ambulance if that provides comfort, if protocols allow, or at least to follow behind. During transport, Sarah suddenly says, "Am I in trouble?" She's likely scared that she did something wrong. You gently assure her, "No, you're not in trouble. You're sick and you're hurting, and we're getting you help, just like we would for someone with a heart problem. You did the right thing by letting us help you." She then says quietly, "Thank you." These small moments can be incredibly rewarding as a provider. By the time you reach the hospital, Sarah is medically stable. You hand over the empty pill bottle and report, informing the ED that this was a serious suicide attempt with clear ideation and that she'll need a psych evaluation after medical clearance. You document her statements, "I want to die," etc., and the fact that she took 30 pills. This scenario shows a relatively smooth intervention, compassionate communication, direct questions, medical treatment, and safe transport. Not all cases will go this peacefully, but many do when handled with care. Sarah's story might have turned out far worse if her friend hadn't called or if no one intervened. As an EMS professional, you were the bridge to get her the help she needs. In a few months, who knows? Sarah might be grateful to be alive. The goal is to give patients that chance. Our second scenario involves both suicidal and homicidal elements. Dispatch info: a 45-year-old male, Alex, who's reportedly intoxicated and threatening to harm someone and then himself. Police are also dispatched given the threat of violence. You arrive with law enforcement. Alex's friend is outside the house and says, "He's inside, drunk, saying he's going to shoot his boss and then shoot himself. I hid his gun in the garage, but I'm scared." Red flags all around. This is potentially very dangerous. Officers go in first, find Alex in the living room, visibly intoxicated and enraged. He's yelling incoherently. They quickly pat him down, no weapon on him now thanks to the friend, and they secure the area. Now it's your turn to approach. Alex is a large man, pacing, fists clenched. He shouts, "Get the hell out of here! You can't stop me!" He is expressing clear homicidal ideation, kill his boss, and suicidal intent. End it, meaning himself. You and the police officer need to de escalate this before anyone can treat him. You speak in a firm but calm voice. "Alex, I'm an EMT. I'm not police. I'm here to check on you to make sure you're okay." He glares. "I'm not okay. I'm going to finish this tonight." You see anger and despair in him. Keeping a safe distance, you continue, "I get it. You're hurting and furious. But I'm really concerned you might hurt yourself or someone else. We're here to help you, not to hurt you." He starts ranting about his boss firing him unfairly after 20 years. You let him vent a bit, nodding and acknowledging, "That sounds incredibly frustrating. I'm sorry that happened to you." By validating his anger, you're trying to build a bit of rapport. He then picks up a glass and throws it at the wall, clearly agitated. The officers look to you, and you exchange a quick plan. He's not responding well enough, might need a physical intervention. You give it one more try verbally. "Alex, I know you want to get back at your boss, but I don't want you to do something that can't be undone. I also don't want you to die tonight. I want to help you." He screams, "You can't help me. Nobody can." At this point, he moves as if he might go grab something, maybe looking toward the garage where the friend hid the gun. The officers decide to act. They move in and, after a brief struggle, manage to safely restrain Alex in handcuffs. It's not gentle, but it's necessary to prevent immediate harm. He's now yelling and cursing at the cops. Now that he's under control, you step in as the medical provider. You quickly assess for any injuries. During the scuffle, he got a small cut on his arm from the broken glass. You dress that. He's still shouting threats about his boss, but now that he's restrained, his energy starts to crash and he sobs, "My life is over." You crouch next to him, mindful of safety still, and say, "Alex, I know it feels that way right now, but we're going to get you through this. You've been drinking, let's get you sobered up and some help for how you're feeling." He doesn't fight as you and the officers get him onto your stretcher. They keep the cuffs on for everyone's safety, which often can be transferred to hospital security at arrival. En route, you monitor his vitals. Blood pressure is high. He's physically fine aside from intoxication and stress. He's mostly quiet now, intermittently crying that he lost everything. You continue to show empathy. "I'm sorry you're going through so much pain. Losing your job and divorce all at once. That's a lot for anyone." He closes his eyes, saying nothing further. At the hospital, he's met by both the medical team and hospital security psych team. You relay that Alex was expressing intent to kill his former employer and then himself, had access to a firearm, removed by friend, and is intoxicated. This ensures they understand the high risk. Likely, he'll be placed on an involuntary psychiatric hold and evaluated once he sobers up. What can we learn here? This scenario was volatile. Scene safety and law enforcement presence were critical due to the homicidal threat. Verbal de escalation alone wasn't enough, but it still helped somewhat. By engaging him, you possibly prevented him from running to get the gun before police intervened. Once restrained, you still treated him as a patient, not a perpetrator, addressed his minor injury, monitored his vitals, and spoke kindly to him. He went from rage to tears, showing that underneath his anger was immense pain. You showed compassion when it was safe to do so, which is important because after he's sober and stable, he'll need psychiatric help, and maybe he'll recall that the EMT, AEMT, or paramedic didn't just treat him like a criminal. In summary, a combined suicidal homicidal case demands teamwork, EMS and police, vigilance, and often quick decisions. You always prioritize safety, but also do what you can to connect with the patient's humanity once they're under control. Both scenarios highlight that EMS is often the first link in the chain for psychiatric emergencies. How we handle those first 15 to 30 minutes can set the tone for the patient's recovery journey. In conclusion, remember these key takeaways when encountering suicidal or homicidal ideation in the field. Always take suicidal or homicidal statements seriously. Even if a patient sounds ambivalent or you've heard dramatic statements before, it's not our job to judge whether it's serious. Treat it as serious. It's far better to overestimate risk and be proven wrong than to underestimate and miss the chance to prevent a tragedy. Many people with suicidal thoughts don't truly want to die. They want help. Their words are cries for help, even if they don't phrase it that way. By responding with compassion and action, you validate that their life matters. Your priorities can be summed up as safety, compassion, and assessment. Scene safety is non-negotiable. Ensure weapons are secured and you have backup if needed. But safety alone isn't enough. You must pair it with compassionate patient care. Approach the person with empathy, listen to their story, and speak kindly. This builds trust and can diffuse intense emotions. Through your assessment, ask those direct questions about suicide and homicide if applicable. It might feel awkward, but patients often find relief in openly discussing it, and you'll gather crucial information. Keep in mind the do's and don'ts we covered. Do stay calm and use a soft voice. Do listen more than you speak initially. Do show that you care and that help is available. Do keep the patient under watch at all times. And do involve mental health professionals as soon as you can by getting them to the hospital. On the flip side, don't be judgmental or scold them for their feelings or actions. Don't say things that belittle their experience. Don't argue with their delusions or emotions. You can't logic someone out of feeling hopeless in that moment, but you can support them despite it. And absolutely don't leave a suicidal patient alone, even for a minute. If you must step away, say to grab equipment, ensure another rescuer or a trustworthy person stays with them. As an EMS provider, your role is unique. You may be the first person to truly listen to that suicidal individual, or the one who prevents a distraught person from ending it all on the worst day of their life. You are the bridge to further care. By recognizing the warning signs, asking the right questions, and responding with empathy and professionalism, you can de escalate a crisis and literally save a life before it's too late. The same goes for someone threatening harm to others. Your actions can protect not just that person, but potential victims as well. It's heavy responsibility, but also a profound opportunity to make a difference. Finally, know that there are resources for patients and for you. The new National 988 Suicide and Crisis Lifeline is a 24/7 hotline text line that anyone can use to get help. While on scene, you might mention to family that they can call 988 for guidance, or after the call, you might use it yourself if you need advice. Never hesitate to involve crisis counselors or mental health teams if available in your system, like mobile crisis units or on call psych. And take care of your own mental well being too. These calls can be emotionally draining for responders. Talk to your colleagues, debrief, and use peer support or counseling if needed. Thank you for your attention. Remember, your compassion and vigilance on these calls are as important as any medicine you administer. By recognizing suicidal and homicidal ideation and handling it with care, you become a critical agent of hope and safety in your community. Stay safe out there and never underestimate the positive impact you can have on someone's darkest day.